Good evening to everybody. Warm welcome on behalf of JB Chemicals and Pharmaceuticals. We are delighted that today we are here for another important topic that we would like to share in proctology. Today's topic is hemorrhoids and anal fissure. And to enlighten us and to take us through, we have with us an eminent speaker, Dr. Kamal Gupta. Dr. Kamal Gupta sir is a consultant surgeon and proctologist and diabetic foot specialist. Dr. Kamal Gupta is certified trained specialist in laser proctology through Berlin, Germany. Most importantly, Dr. Kamal Gupta sir has performed more than 1,000 surgeries in laser and minimal invasive proctology, and he has operated 23 live workshops and participated in 32 symposia as a panelist. He has got a lot of publications to his credit. I think without taking much of the time, because if I take time on that, probably we would be really missing on what Dr. Kamal Gupta would like to say. So I would hand over the dais to Dr. Kamal Gupta, sir. Sir, on to you, sir.
Yeah, thanks, Dr. Pranav, for a nice introduction. So, may I share my screen, please? Yeah, good evening, friends. It's a pleasure to be once again back with you. As Mr. Shah has already said, that today we will be sharing our views on hemorrhoids and fissure in anal. So once the presentation is over, I will be taking over the question and answer sessions also. Now I shall be covering the relevant anatomy of anal cushions and a part of the anal fissure. Because in my opinion, till we understand the basics of the anatomy, the principle behind the laser surgery, or as such, the principle of management of hemorrhoids in a surgical way is incomplete. So coming to first the anal cushions. So anal cushions are disruptions of submucosa at 3, 7 and 11 o'clock position. And the anal cushion theory was first described by Thomson in 1975. Now coming to the contents, anal cushions, they have sinusoids. They are present in the form of fenestrations having the epithelial lining, then connective tissue and elastic muscle fibers. They are held at their normal positions by ligament of Treats. And what is ligament of Treats? It's a suspensory ligament. Now it is formed, as you can see, this is a conjoined longitudinal muscle, which is a continuation of the outer layer of the rectal wall. That is a longitudinal muscle. After that, medially, it gives the fibers like this, which pairs the internal sphincter, and this leads to formation of the ligament of Treats. Now, with the help of Treats, the anal cushions are held at their normal position. So what happens with age, once the ligament of Treats, they start becoming weak or breaking down, then the anal cushions, they start sliding downwards. Now that is where the anal cushion theory by Thomson is based. Yeah, just hold on, please. So that is what the anal sliding anal cushion theory is based. Now, if we talk about the classification of hemorrhoids, that is based on prolapsing theory. When we talk about grade 2 to grade 4 hemorrhoids, they are all based on anal cushion sliding theory. So that is the reason the anal cushions, they form the basis of hemorrhoids. Now coming to the blood supply, now we know above the dentate line, the blood supply is from superior hemorrhoidal artery, and below the dentate line, the blood supply is from the inferior hemorrhoidal artery. But one thing is very important, that there are present anastomosis between the superior and inferior hemorrhoidal artery. Now that is a reason when many surgeons who go for Milligan Morgan, and in spite of going for ligation of the pedicle, still the bleeding is there. Because when you go for ligation of the pedicle, basically you are ligating the branches of superior hemorrhoidal artery, which are supplying to the anal cushions. Another most important thing, when we talk about Dr. Chipte's procedure, that is transanal suture hemorrhoidopexy. Now, what Sir suggests, that in case you go for transanal suture hemorrhoidopexy, there can never be any avascular necrosis, which is very true. The reason being, because there are present anastomosis between SHA and IHA, that is the reason there is never a vascular necrosis. Now, coming to the relationship between portal hypertension, rectal varices, and hemorrhoids. Now, many people ask how to deal with such a situation. Now, please remember that the bleeding from rectal varices, it occurs only in 5% of cases. The bleeding is red, bleeding per rectum, it is a red blood, fresh blood like hemorrhoids. Secondly, most important is the history of the patient. If before going for a procedure, we have examined the patient, we have taken the history, naturally variceal bleed can be ruled out there only. On examination, the most important thing to differentiate between hemorrhoids and rectal varices is that in rectal varices, there are bluish color longitudinal columns. Whereas in hemorrhoids, there are present either sulci or radiating folds. So that is a very important part to differentiate between the two conditions. But still, whenever in doubt, please don't go for any operative procedure. Whether you are going for minimal invasive procedure like laser hemorrhoidoplasty, or you are going for Milligan Morgan, please do not go for such procedures whenever you are in doubt. And at that time, the choice remains either transanal suture technique, which is Dr. Chipte's procedure, or sclerotherapy. Now, in case any patient comes to me, I will straight away go for sclerotherapy in these patients. Now, coming to the first topic of laser hemorrhoidoplasty. Now, when I go for laser hemorrhoidoplasty, the first step which I go is for finger guided hemorrhoidal artery ligation. Now, I always like to do a hybrid procedure. I think the results with hybrid procedure are much better as compared to simple laser hemorrhoidoplasty, although many surgeons are doing that. They are not going for HAL before laser hemorrhoidoplasty, and in literature also it is mentioned that you can go for LHP without going for HAL. So coming to the principle, why I go for HAL, now coming to the principle of HAL, that is hemorrhoidal artery ligation, was first published in 1995 by a Japanese surgeon Morina. Now, when we talk about HAL, the first thing which comes in our mind is Doppler guided hemorrhoidal artery ligation, that is DGHAL. But if we go through the literature, the first simple ligation for hemorrhoids was carried out by Blaisdell in 1958, and the paper was published in American Journal of Surgery. So what do we get once we are going for HAL? So what are the advantages? Well, just remember the few basic things. The position of rectal artery is not predictable. Arterial blood supply is of relevance for the pathogenesis of hemorrhoids. Previously, it was thought that maybe hemorrhoids is a venous disease. But without doubt, now it is very clear that it is a arterial disease. Then ligations can be effective in the distal part of rectum. Hall is an effectively ligating procedure, and Hall is responsible for care of symptoms. Now, there was a publication by Eigner in 2004 where he explained the superior rectal artery and its branching pattern. Now, as you can see, it is very well postulated that the vessels never always were present at 3, 7, and 11. So they may be present, anal cushions we know are present at 3, 7, and 11, but the position of the, vessels may not be constant. And another thing, when the vessels are present in the distal part of the rectum, that is the branches of superior hemorrhoidal artery, in 82% of cases, there is bifurcation, and in 12% of cases, there is trifurcation. Now, as I said, the position of the arteries is not predictable. Now, what our traditional teaching was that the vessels are normally present at 1, 3, at 3, 7, and 11 o'clock positions. Later on, it was postulated that the vessels may be present at 1, 5, and 9 o'clock position also. And when we talked about hemorrhoids, the hemorrhoids were also classified according to that. So what they said at that time, that at 3, 7, and 11 o'clock position, the hemorrhoids which are present because of anal cushions, they are called primary hemorrhoids. And in case hemorrhoids are present anywhere else, they are called secondary hemorrhoids, which is not true. Because secondary hemorrhoids, they normally occur as a result of some disease, for example, C. rectum. And these hemorrhoids, which are present, they should be called accessory hemorrhoids. And believe me, the position is not constant. So don't always think that 3, 7, and 11 is constant, whereas 1, 5, 9 is also constant, which is not true. As the position of rectal arteries is not predictable, only thing is you will have to palpate and see when you are performing your procedure. Now, coming to the vascular nature of hemorrhoids, now superior hemorrhoidal artery, which is a continuation of inferior mesenteric artery, now it divides into either you can say anterior or posterior or left and right. Then further, it gives rise to 3 to 4 branches each. And finally, in the distal part of rectum, when we talk about bifurcations or trifurcations, this is how we see the branches of superior hemorrhoidal artery in the distal part. Now, another landmark publication which came in 2006 was again from Eigner on vascular nature of hemorrhoids. And it was very clearly proved that in hemorrhoids, as compared to normal human beings, there is 3 times increased blood flow. So this led to a theory that was popularly known as hypervascularization theory. So that is one of the most important etiological factors in hemorrhoids. So now we know the importance of ligation. The next thing is how deep we have to go and where exactly we have to go. Well, we are 2 to 4 centimeters above the dentate line. At that time, the depth of the vessels is just 3 to 5 millimeters. So that is a place where we are supposed to go and ligate the vessels. If we keep on going up, the depth of the vessel will keep on increasing and it will be very difficult to go for ligation. Now, this is the exact point where we should go for the hemorrhoidal artery ligation. Now, this is 2 to 4 centimeter above when I talk about dentate line. So that is the apex of the pile mass. So that is the place where we should go for ligation. Now, which thread to use? Well, in routine, we use 2-0 Vicryl. It's a special heart suture, which is 27 needle thickness, 5 by 8 circular round body needle, and the length of the thread is 120 centimeter. This is from this thing for Lotus. From other companies also, the same thread is available. The only difference is in the length. In the other companies, maybe it is 90 centimeter or 100 centimeter, but in Lotus it is 120 centimeter. Now coming to the principle of laser energy. So now we know about the first step, that is Hall. Now coming to the second step, that is what does laser do exactly? Well, the laser energy, which is a thermal energy, it leads to photoablation. A photoablation means it breaks the chemical bond, that is H2O bond. The H2O bond is broken, hydrogen is released, and that is the reason on the release of hydrogen, you get the popping sounds when we are going for a procedure. Second, it leads to photocoagulation. Now we know that the protein denaturation starts at 72.6 degrees Celsius and it goes up to 132. Now what happens when the thermal energy is released? It leads to protein denaturation, leading to sealing of the blood vessels. So once the blood vessels are sealed, it leads to shrinkage. Then photovaporization. Now we know the blood contains 70% of water. And once the thermal energy is gone, the water content gets evaporated, leading to shrinkage of the bile mass, followed by formation of a clot or a coagulum, and then it leads to fibrosis. Now that is the principle behind the laser hemorrhoidoplasty. That is why the hemorrhoidal cushions, they get stuck to their normal position. So the process basically remains fibrosis. Now coming to the technique, how to do it? Well, the fiber which we use is a conical laser fiber. Make sure light is not very bright, and the most important is point of entry. Now initially when I started, I used to go from mucocutaneous junction somewhere from over here. But then when you see the anatomy of some mucosal space, we know the submucosa ends at dentate line. And further, we know that anal cushions, they are disruptions of submucosa at 3, 7, and 11 o'clock position. So the point of entry remains the dentate line. So that is the most important part, why we should enter from the dentate line. Then dosage at the time of insertion of fiber, it is 6 watts 1 second pulse. And once we start the coagulation, it is 6 watts 3 second pulse, and we keep on withdrawing the fiber every half a centimeter. Total energy should not exceed 200 joules per pile mass. That also when the pile mass is bigger. But if you are at grade 2 or grade 3, then maybe 70 to 100 joules will be given because you are entering from the dentate line. Now, what not to do? Now, that is a very important part for all of us. Never try to push fiber against resistance. In case you feel there is any resistance, it means you are not in the correct plane. Never activate laser if the light is too bright or too dull. Too light means you're very near to the mucosa, you can go for mucosal burns. And in case it is too dull, that means you are somewhere in the internal sphincter. And if the pile mass does not shrink on giving continuous energy, please stop. Don't keep on giving more energy because the pile mass may not shrink immediately. But yes, eventually it is going to shrink. But in case you keep on giving more energy, what is going to happen? The energy, which is a thermal energy, it is going to lead to cell death. That is, it is going to lead to inflammation. And that is the reason you get a lot of edema post-operatively after laser hemorrhoidoplasty. Now coming to the procedure, now this is third degree hemorrhoids. The most important part is assessment of the hemorrhoids, as you could make out at 7 o'clock position. Now this is how HAL is done. So the first step which we do is hemorrhoidal artery ligation. So just focus on the way I am holding the needle holder. It is pronation and supination movements of the needle holder. Go at the apex of the pile mass after palpating with the fingers. Very nicely you can palpate. And that is a figure of 8 stitch which we take. Thread used Vicryl 20. Now this is for milking. So once you have gone for this, go for milking, and similarly keep on rotating at other places. So you can feel the vessels with the finger and keep on ligating them. So that is the way the first step is taken care of. And once you have finished the ligations, keep on rotating your proctoscope, which is a half-cut proctoscope, for 360 degrees. Palpate in case there are any vessels which have been left unattended. And after that, the second step which we go for is the laser hemorrhoidoplasty. Now this is how the fiber you can make out. Now this is a dentate line from where we are taking the fiber inside. And once you are inside, automatically the fiber is going to stop at the tip where HAL has been done. Because we know we were in submucosal space and the fiber is also in the submucosal space. Now just enter, make sure the light is not too bright or too dull. And in case it's a big pile mass, you can go in a fan-shaped manner. That is, first go straight, then left and right, and keep on withdrawing every half a centimeter. Now that is at 11 o'clock position. So you can make out the pile mass is reduced. And finally, we do insert a ice finger for 20 minutes. Now, many people say that it's better you go for, cooling before laser. Maybe the submucosa will become more cold. The thermal energy damage is going to be less. I have done few cases. And secondly, we have gone for spraying even during surgery or after surgery immediately. But we don't find any difference as far as edema is concerned. But definitely, since we have started going from the dentate line, the edema is really less. It is actually less as compared to when we used to enter through mucocutaneous junction. Now coming to the next, that is 4-degree hemorrhoids. Now you can make out the picture. Lot of edema is there, and this is grade 4 hemorrhoids. Now the first step which we do in such patients, we go for injection Hyalase. Now what Hyalase does? Hyalase increases the tissue permeability. So once the tissue permeability is increased, there is reduction in the edema. So once the edema is reduced, which you will find in few seconds, then the pile mass will go inside. And once it goes inside, it doesn't matter whether we are dealing with grade 2 or grade 4 hemorrhoids. And this is a common drug which is used by many ophthalmologists. Now, once you are injecting Hyalase, just inject into the pile mass itself. Withdraw the piston, make sure that there is no blood. So once there is no blood, just release the Hyalase solution. It is available in 1 ml vial and 1500 international units are there. You can dilute it with distilled water and then you can make 1 ml solution and inject it. And people do ask how much we can inject, whether it is 3, 4, 5 ml. But honestly, you can inject even up to 10 ml. There is no limit as such. So I've never had a need where I had to inject more than 3 or 4 ml. But yes, in case somebody, I mean, the pile mass is big, a lot of edema is there, you can inject even more. So coming back to the Hyles, so this is how the injection is given. You can make out a reduction in the pile mass just on the table. So now once it is inside, it really doesn't matter which degree we are dealing with. Now that is a standard routine procedure. As I said, I always go for FG Hall as a first step. So that is at 3 o'clock position. That is a milking. The assistant's finger comes inside. So this is basically, it leads to disengorgement, reduces the pile mass. So keep on palpating and keep on ligating. You may not find 6 to 8 branches, but definitely 5 branches, 6 branches maybe you can find, may not be 8. Now that is evacuation of clot. Now the patient had thrombosed hemorrhoids. Now see this. Now this is a standard Corman teaching. It is very clearly mentioned that in cases of thrombosed hemorrhoids, you can go for clot evacuation. So this is what we did in this case, grade 4, thrombosed hemorrhoids. We removed the clots or the thrombi which were present over there. After that, we took the laser from the same point. Now that point became our entry point for laser. So just remove the clots. So this is the skin tag or anal papillae. It's anal papillae, rather hypertrophic anal papillae, which is present over there. So that is excised, and remaining steps of laser, they remain same. So why we prefer Hall with laser? Well, two etiologies are taken care of. The hypervascularization theory, which was given by Eigner in 2006, that is taken care of by hemorrhoidal artery ligation, and sliding anal cushion theory by Thompson, that was given in 1976, that is taken care of by laser hemorrhoidoplasty. Postoperative antibiotics you can give a shot before and maybe in the evening. Analgesics routine, we just use Justin's Postis, that is diclofenac. And cold pack, as I said, we keep it for 20 minutes. And next day, we ask the patient for sitz bath, and laxatives of your choice you can give. Now, advantages: no surgical trauma as compared to Milligan, Morgan, or Ferguson. Of course, minimal surgical trauma is always there because we take the fiber through entry point. Significantly less pain because you have not cut anything, and early return to work. 3 days as compared to 21 days on an average with Milligan Morgan. And the concept offers both effectiveness and safety as far as it is compared with the other procedures. Now, this is how the preoperative picture is, and that is how the postoperative it looks. Grade 4. Now, this is a part of edema which is present over there. You can make out. Now, we had few publications. This was with my respected teachers, Dr. Kushal Mittal and Professor Ramakant. And it was a study conducted on 252 patients and FG Hall with laser hemorrhoidoplasty was very effective, and the results were spectacular, almost 98%. Now, another study which was done by Ramakant sir along with Dr. Kushal Mittal and me. Now, in this, we had compared DG Hall with FG Hall, that is Doppler guided with FG Hall, because Ramakant sir, he was doing a lot of DG Halls, that is Doppler guided hemorrhoidal artery ligation, and we found no difference in the results as far as DG Hall or FG Hall was concerned. Now, coming to the complications, as I said, edema can be there because of cellular injury. Then hemorrhage and abscess, yes, they can be there. Hemorrhage in case the mucosa has been, penetrated, or it has been, you were too near to the mucosa when you were releasing the laser. Abscess formation, yes, I have seen in one case myself at 11 o'clock, the patient developed abscess. I don't know why it happened, but yes, it is reported in the literature also. Thrombosis, which are basically the clots, and skin tags, in case it's an internal-external hemorrhoids. Then skin tags may be left after surgery. Now, coming to the take home message, less is best, minimal pain, least risk of complications, no tissue trauma, absolutely bloodless field, and a very short hospital stay. Now, these are overall results. And as I said, the publication which we had, myself and Dr. Kushal Mittal, it was 252 cases, and the results were at par with world. 98%, 98.9%. So all over we were at par with the world. Now, some interesting facts. Now we know that the anal cushions, they play an important role in anal continence. 15 to 20% of resting anal pressure or resting anal tone is maintained by anal cushions. Milligan Morgan started in 1937, but the anal cushion theory by Thomson was given in 1975. So Milligan Morgan did not know that they were cutting anal cushions. Today, we know when we are going for open hemorrhoidectomy or Milligan Morgan or Ferguson's, then we are cutting anal cushions. So whether Milligan Morgan should be considered as a gold standard, well, it's up to us to decide. Now, coming to the next topic, that is fissure. Now, I will be covering only the basic anatomy and the common asked questions, when I go to any conferences or maybe I go somewhere to teach, at that time what people ask. So anal fissure, all of us know very well that it's a linear tear in the anal canal or anal verge that may extend up to dentate line. Now, the commonest question which is asked, why anal fissures, they are present most common posteriorly? Well, the simplest answer is the blood supply is the posterior commissure is far less as compared to anterior commissure. So that is the reason the fissures that tend to occur most commonly posteriorly. Secondly, why it is up to dentate line? Now this was explained by Golliger that the anal fissures, they occur up to dentate line because the internal sphincter is quite spastic from dentate line to anal verge. So that is the primarily reason why the anal fissures are limited up to dentate line. Of course, I am not including the fissures which occur as a result of maybe Crohn's or ulcerative colitis. Then, why in females anterior fissures are more common? Well, the answer lies over here. See this. See this. Now, laterally on both the sides, whether at 3 o'clock or at 9 o'clock, both the sphincters, internal and external, they are in close proximity. Whereas both anteriorly and posteriorly, there is present loose areolar tissue. And anteriorly, in women, the sport is believed to be a cause of anterior fissure. Now we know that there is perineal body, then there is a loose areolar tissue. Now that is the reason, because of lack of proper support to the sphincters. That is the reason the fissures are more common anteriorly in females, whereas they are more common posteriorly in males. Now, what to do in case a fissure is present? Well, the answer is lateral internal sphincterotomy, which is considered to be a gold standard. Different techniques are there. You can go for open technique or a closed technique that is called CLIS, or you can go for laser in case you have laser. Otherwise, uh, there is no particular advantage of laser unless you are going for actually a minimal invasive procedure for laser lateral internal sphincterotomy, which I will be sharing with you. And why not to do sphincterotomies at 6 o'clock position? Well, all of us know because of the presence of loose areolar tissue, there, there may subsequently form a defect which is called a keyhole deformity. Now, this is because of constant seepage of the liquid part of the motion. How much sphincter to cut? Well, in case the tone is increased, the recommendations were go up to dentate line. But if there is mild spasm, then cut up to the length of fissure. Now, this is what was the standard teaching. But if you go through the practice parameters of American Society, it is very clearly mentioned that irrespective of the length of anal fissure, you should always cut the internal sphincter up to dentate line. And in case the anal tone is normal, in those cases, please do not go for sphincterotomies. The patient will end up with incontinence. So the choice of procedure in such cases remains anal advancement flap. Advantages of laser: internal sphincter can be seen under vision. In case you are going for open the way I do, I will just share the video with you. It's a bloodless field, absolutely bloodless, because what I have seen in CLIS, after CLIS, whenever I used to do the closed rectal internal sphincterotomy, I always used to get a lot of bleeding. So I personally feel the bleeding is there in CLIS because when you rotate the blade medially, we know the vessels, they penetrate the internal sphincter vertically. They go vertically up. So that is the reason maybe the vessel is ruptured at that time and then the bleeding occurs. And why laser? Because with laser, there is no lateral spread of current as compared to electrocautery, and no chances of partial sphincterotomy in case you are doing it under vision. So coming to the first video, that is laser LIS, you can make out an anterior fissure. Now this is a dentate line. Now see this depth, this part, that is the intersphincter groove. We have to enter in the groove. So this is the laser. It's a bare fiber which we normally use. It has got both hemostatic and cutting effect. Now rotate it medially, go up to dentate line gradually like a saw. You keep on cutting the fibers and come out. And if you want to check whether proper sphincterotomy has been done or not, insert a mosquito, you can make out very few fibers have been left, hardly 2 or 4%. So in case you want, you can go for, lysis of those fibers with fingers, or you can insert the laser fiber again and you can cut it with that. Then for the removal of the sentinel piles which were present anteriorly, so we prefer to invert the proctoscope and cut radially. So that is the way we can do it. Now coming to the next. Now this is another technique. You can make out the fissure middle and posterior. This is the internal intersphincter groove. So make 3 to 4 mm wide incision with the help of laser. It's a very fine cutting. We know with laser is always a fine cutting. Now go inside. This leads to hemostatic effect. Then take a mosquito, bring the internal sphincter out. Now your left finger is guiding you up to dentate line. So bring it out. We know the thickness is 3 millimeters of internal sphincter. So just take it out very gradually and then spray the laser on the points where you can see the small bleeders and then cut it gradually. It's a real-time video. It hardly takes 40 seconds to perform this procedure, and this is immediately post-operative picture. Now, as I said, LIS is a gold standard, and grade of recommendation is 1A. Thank you very much. That finishes both the topics, that is hemorrhoids as well as anal fissures. So, as I always say, the most dangerous phrase is we have always done it this way. When laparoscopy started way back in early 90s, people used to criticize it. Still, people used to say at that time, open laparoscopy or open cholecystectomy is much better than laparoscopy. My teachers used to say at that time. And when EVLA, that is endovenous laser ablation, it came in a big way way back in 2004 or 2006. People still used to say for varicose veins, open or ligation or stripping is the best. Today, we know in almost all abdominal surgeries, it is the laparoscopy which is being done. At the same time, for varicose veins, it is EVLA which is considered to be gold standard. So whether you want to go for laser or you don't want to go for laser, well, it is anybody's individual choice. I prefer to do this way whatever should be. Thank you very much once again. So any questions, if they are there, I am willing to take.
Thank you, Doctor. So on behalf of JB Chemicals and Pharmaceuticals Limited and our entire medical team, I, Dr. Jay Savai, would like to first of all take this opportunity to thank our eminent speaker, Dr. Kamal Gupta, for his wonderful session. And his session was really very informative. Sir has given a very deep insights, and beautifully, sir has given all the latest clinical data, evidences, and also some of the important examination videos. I think it was really interesting, and the session was very, very informative. And sir, the session, you really made it interesting as well. And I believe that today each and every one of us have learned something new and would inculcate them in our practice. And now I would request all our viewers to put down their questions in the chat box, which you can see in front of you. You can type across your questions. If you have any queries, you can post it across, and we would take it one by one. Sir, I have received some of the queries. I'll just ask you one by one. There's one question which has been asked from Dr. Rao from West Bengal. Sir is asking, what is the line of treatment for any non-healing wound after surgery in cases of anorectal region, in anorectal conditions?
That's absolutely different topic. I don't know which surgery he's talking about. Maybe when we are going for any our series on wound healing, maybe the time principle or something when we discuss, I think that question can be taken at that time, because he has not mentioned about which particular surgery, which particular wound he's talking. I think generalized wound, if he's talking,
Sir,
then I will just say
anorectal wounds in anorectal region.
then I will say that in case the wound is like a fissure, or go for sitz bath. That is the number one part. Keep the wound clean. That is very important. And in sitz bath, please do not add Savlon or betadine. And the drug of choice, you can go for enometrogel, which is a combination of metrogel, sucralfate, and lignocaine. That is one of the best treatment which is available.
Okay, right. Sir, what are your results when it comes to use of laser hemorrhoidoplasty in fourth degree hemorrhoids?
Dr. J, the results are very good. In a few patients, I have seen that after some time, in grade 4 I'm talking, that there has been some relapse. But that is the reason when I mentioned about my results, it's 98%, and 2% are perhaps those cases where we had internal external hemorrhoids, or maybe grade 4 hemorrhoids. But as far as grade 2 or grade 3 are concerned, there is no problem at all.
Sir, there's another question from Goa. The question is, how effective is Botox injection in anal fissure?
People are doing it. They are happy with it. But if you go through literature, the mention rate, success rate is 64%. So I do not do, because initially I go for, a combination of, any calcium channel blockers, that is diltiazem or nifedipine along with lignocaine. Then in case the patient does not have any relief after that, or there's a relapsing fissure, I must say that, then it is better to go for LIS. So Botox as such, I don't practice, but the results, as I said, is 64% as per literature.
There's another question, sir. Any criteria specific per se for with respect to surgery in anal fissure cases?
As I said, that initially, always we should go for medical management. So that is the standard practice with me. In case the fissure does not heal, at least in the 6 to 8 weeks, then, and in case the patient keeps on complaining about the pain during defecation, then those are the cases where we should go for lateral internal sphincterotomy.
There's another question from Maharashtra, Dr. Naikwade. Treatment for fourth degree hemorrhoids, if you can highlight on.
Yeah, actually, basically, first of all, I would like to say there was a theory which was called rectal mucosa, redundancy theory by Longo, that was given in 1990. So that was a time when staplers were in vogue. Of course, in India today also people are using a lot of staplers. So if you're going for staplers, if you're already doing it, so in grade 4 you can go for stapler hemorrhoidopexy, At the same time, if you think that only one, 4-degree hemorrhoids are there, one part is the part which is not letting other pile masses also getting reduced. It's better to only remove that particular part. But in case a patient comes to me with grade 4, and in case there is no rectal mucosa redundancy, secondly, there is no gangrene, or there is no ulceration or strangulation or any signs of infection, I will just go for laser rhinoplasty. But it remains individual choice and your experience.
So there's another question is like, what are the percentage chances of recurrence following the laser therapy?
As I mentioned, that chances are always there. Still, in out of 100, as I said, 2% cases are always there.
Sir, any calcium channel blockers formulation do you recommend for patients suffering from anal fissure?
Uh, lately nifedipine and lignocaine is available with a tube sort of a thing, which you can insert, and it releases the drug, which is 1.5 grams per, release, and there are disposable tips which are available. So you can go for that. Otherwise, even diltiazem is very good. GTN I don't use.
Okay, right, sir. Sir, do you recommend any topical anti-infective ointments following anorectal surgeries, and which one do you prefer and for how long?
Anorectal surgeries are concerned, we do go for metrogyl. The choice of drug for us remains enometrogel, although it is from your company. I should not be saying much about that. But yes, enometrogel is a drug of choice. Local, suppose any wound is there, maybe after fistula or maybe after fissure also. And the drug of choice in my practice remains enometrogel. Or maybe metrogel is plain also.
There's another question with respect to therapy, sir. So which laser, do you prefer for, do you recommend for the colorectal surgeons? Could you give any
1470
recommendation?
nanometers. All the companies are very good. You can go for any company you like, but I prefer 1470. I have been using 1470, and the advantage of 1470 is that it is much faster as compared to 980. Although it is slightly more expensive, not very expensive, but slightly more expensive as compared to 980. But the another advantage which we have with 1470 is that you can use in varicose veins also, because it works under water as a medium.
Right. So another question is with respect to, can anal fissure surgery like a lateral sphincterectomy or fistrectomy can be done in presence of local anesthetics, and what are the treatment for multiple anal fissures?
Multiple anal fissures, you have to rule out other causes like HIV, Crohn's, ulcerative colitis, and syphilis. First, rule out that. And secondly, there were two parts of the question. So that was multiple. And second was, Dr. J, please repeat the question.
Can anal fissure surgery like lateral sphincterotomy or fissurectomy can be done in local anesthetics?
Yeah, definitely. We can go for SEPTA. That is a technique which has been taught to me by my respected teacher, Professor Ladda. And that is, basically a pudendal nerve block. So any patient who comes to us with low ejection fraction, that is maybe up to 30%, the cardiac patients, I prefer to do all my cases under local anesthesia. That is septal block or pudendal nerve block. But the most important is, just even if you are doing it under local, always keep the anesthetist by your side.
So there's a question with respect 6 o'clock position. If we do fistulotomy, will this lead to keyhole defect and seepage? If yes, what surgery would you suggest in this case?
If you're talking about fistula in ano at 6 o'clock position, yes, definitely we have to go for fistulotomy or fistulectomy at that time. Of course, the results of fistulotomy and fistulectomy, they remain same. Only thing is you're creating a much larger wound with fistulectomy. So in those cases, there is no other choice but to go for fistulotomy at 6 o'clock position. And yes, keyhole deformity should be a acceptable form of deformity by the patient as well as by the surgeon. And it's better in case we can explain that thing to a patient beforehand. Although patient does not know about that, and we as surgeons, we know that it can lead to keyhole deformity, but there's no other alternative in that. But in case we are not there, I would like to add over here, in case point of going for fistulotomy, then we can go for other procedures like distal laser and proximal slough and all, DLPS. Many other procedures are there which are in part of minimal invasive surgery. Those can be taken.
There's another question from Goa, sir. Do you do internal sphincterectomy in anterior fissure in females? And if not, is there any other technique do you do?
No, I have never done any, fistulotomy anteriorly. It is absolutely a big no for everybody, all of us, because we know that there is a perineal body which is present over there, and there can be incontinence. As such, why to go for fistulectomy? It's not recommended anymore. The standard of the treatment of choice, that is lateral internal sphincterotomy. Whether it's male or females, you can always go either at 3 o'clock position or 9 o'clock position.
So there's another question. When would a fissure lead to fistula formation?
Good question. I will say that when the fissure tries to heal, now what happens from both the sides, the sentinel piles is formed. Now the sentinel piles, they are basically protective piles which try to, the skin becomes hypertrophic and it tries to cover the fissure site from the center. So that is a condition where sometimes a fistula formation takes place. It's a common condition which we see in our day-to-day practice. And in my opinion, the fistulas which are formed are normally subcutaneous, but they may be intrasphincteric also. So just keep in mind when you are thinking about presence of a fistula along with the fissure.
Right. Sir, any complications do you see following post-operative doing laser operations in?
Yeah, I had post-operative bleeding in 2 patients out of maybe 1,000, but they just told me that they had bleeding. And when, that must be a secondary bleed because that was after 10 days or so. But when I saw their, the treatment chart, which they had sent to me, one patient was from England, from London proper, and they was not mentioned anything that there was a bleeding because of, laser. So I do not know what was the cause. But when he sent me the paper, it was very clearly mentioned that on proctoscopy or sigmoidoscopy, they could not make out any bleeding from the operated site. So, but yes, if you go through the literature and in case the mucosa, sometimes may be burned or maybe there is ulceration, yes, bleeding can be there. In my opinion, when the bleeding happens, it is mostly secondary. And secondly, later on also I have seen sometimes the patient presenting with bleeding, and this happens mostly in those patients who remain constipated for a long time. Even after surgery, they remain constipated. That is the most important thing. The constipation thing has to be taken care of.
Right, sir. There's another question with respect to topical usage. Is when you use povidone iodine locally, does it induce any unnecessary hypergranulation, sir?
On the contrary, povidone iodine concentrated form is used in hypergranulation. It is one of the treatments. Now, what is the principle behind povidone iodine? That everybody has to understand. Then, first of all, it should not be used. In my opinion, it should not be used. Why so? Because, first of all, it doesn't cross the biofilm. Whenever there is a wound, there may be a biofilm formation which is present in approximately 60% of the chronic wounds and 6% of the acute wounds. And povidone iodine is a cytotoxic drug in itself. And because of that cytotoxic effect, maybe sometimes we use it in hypergranulation tissue. So povidone iodine leading to hypergranulation, I don't think it can lead to that. Because by nature, it inhibits the formation of fibroblast, or it acts on the fibroblast and delays the healing.
Right, sir. So there is another question is with respect to fistulectomy surgery. Will it be damaging to sphincter, and can it be more dangerous? So it could be damaging to which sphincter, internal or external?
Uh, Fistulectomy, damage to the internal or external, but depends upon the type of fistula we are dealing with, the type of surgery we are dealing with. You know, if it is basically a perianal abscess, which has ultimately gone for a fistula, that means it's an intersphincteric fistula. But if it's a long fistula, and if the more than 50% of external sphincter is involved, then definitely the patient can go for incontinence in case you're going for open surgery. In my practice, I do not go for open surgeries at all, except for the fistulas which are less than 4 centimeters in length. So once you are going for fistula surgery, try to learn sphincter saving procedures. WAFT is there, then minimal invasive procedure like SLOFT, that is submucosal ligation of fistula tract, which has been very much popularized by Dr. D.U. Pathak. It's a very good technique, which is alternative to lift. And then third, lift itself is a very good procedure. So we have got so many with laser. We can do so many procedures of this SLOFT with laser. We can do lift with laser. We can do waft with laser. We can do. There's no point of cutting the sphincters.
Right, sir. There is another question from Dr. Pasanna Kumar from Odisha. Is fissure in patients under psychotropic drugs? Any possible causes, sir?
As he's mentioned about the drugs, any drug which is like statins, for example, I'll just give you an example. Like statins can lead to constipation. So any drug which is leading to constipation, those drugs have to be stopped.
Another question from Gujarat, sir. Can we do LIS for recurrent anal fissure?
Definitely. Relapsing, that the name given to that condition is relapsing anal fissure. Yes, the treatment choice remains latent anal sphincterotomy. And I have, although I have never done any case like that, but I have read that in case there is relapse, even after latent anal sphincterotomy, maybe at 3 o'clock position you have done, maybe 6 months back and so. And in case the patient gets it back, you can always repeat the procedure at 9 o'clock position also.
There's another question with respect to in fissure Lot's procedure, a debridement of fibrous tissue is good or not?
Very good. It should always be done. I always do in my practice. Then we have gone for latent anal sphincterotomy. The base of the fissure should always be curated. It's a standard procedure. And in case you can see grade 4 fissure, I mean, that is all you can see the internal sphincter fibers lying over there. It's better to take a small, mosquito from there and rotate it towards 3 o'clock position or maybe 4 o'clock position and cut the sphincter from there. You need not to create any other wound. You need not make any other entry for latent anal sphincter.
There's another question is, what is your opinion about sclerotherapy?
Sclerotherapy is good. We do it in routine for grade 1 hemorrhoids. As it's an office procedure, so grade 1, three most important procedures remains IRC, then band ligation, rubber band ligation that is called, and third is sclerotherapy. These are the three ideal procedures for office procedures. And anything you want to do, whichever is your choice, up to grade 2, you can go for it.
Sir, I think there's one question from Maharashtra is with respect to the cost of 1470 laser. Of which brand do you prefer?
No, I don't prefer any particular brand. As I said earlier also, that whatever equipment is available in market, all the equipments are good. I always would like to go for equipment where recurrence cost is less. I know some equipments are available in market where after 6 months they ask for calibrations. So during warranty period, you can always say it is fine. But once the warranty is out, then you have to spend 40,000 rupees every time. You have to call an engineer. So that those sort of things I would not like to go. Second, those equipments where there is a locking mechanism, means the fibers they get locked after 2 surgeries, 3 surgeries. Those are the cases where I would not like to go for those equipment. So I will prefer an equipment where I can discard the fiber when I feel it is not working properly.
There is another question, sir, with respect to in fourth degree hemorrhoids. Which one is better, laser treatments or the Chivits procedure?
Individual choice. I think people are going for open procedure also. Lot many people are doing stapler hemorrhoidopexy also. And in my practice, I go for laser because I think I can do it better in laser. But sometimes in case there is as I said mentioned earlier, there's a gangrenous part or maybe there's infected part. That part I will remove by doing Milligan Morton. Rest of all the piles which are present over there, that I will go for laser rhinoplasty.
Sir, in case of perianal abscess or any other do you prefer? I mean, which one is better, mupirocin or povidone iodine?
The problem with mupirocin is that it acts on MRSA. It is basically meant for methicillin-resistant Staphylococcus aureus. And secondly, this is a drug which is more popular for gram-positive bacteria. But when we talk about perianal infection, and in case there is, any continuation with the internal opening, that means the fissure formation can be there. The organism which will be there in the pus, in case you send it for pus culture sensitivity, it is going to be either E. coli or Klebsiella or bacteroid species. So these three things are going to be there, and they are all 3 gram negative. So the drug which does not act on gram negative should not be used.
Right.
Secondly, as far as povidone iodine is concerned, I use in my practice routinely the silver wash because I personally feel silver is a better solution as compared to povidone iodine. So in my practice, we are not using povidone iodine at all. We are just irrigating the wound with distilled water, followed by, or maybe with silver wash. And even the ointment I have to use, then I prefer to use this thing, metrogen ointment, locally.
Sir, that's it. I think, sir, most of the questions have been covered. Many of them, they are repetitive, sir. So, sir, any final conclusions that you would like to give it to your viewers, sir?
Yeah, I will request all my colleagues that no one procedure is perfect for any surgery. So do whatever you think is best in your hands. Do not start laser because somebody else is telling you to do lasers. If you're happy with Milligan Morgan or if you're happy with staplers, your results are good, your patients are happy, please continue with it. That should be the take-home message from my side. Same is with Fissure also. I do Fissure with laser because I have got equipment. But in case you ask me, is there any real benefit with laser as compared to use of a cautery? I will say no. In case you are happy with the cautery, you please continue with it. I do it because, in my opinion, maybe electric cautery gives 300 to 400 degrees Celsius heat as compared to 100 degrees with laser. And secondly, because I have got this equipment, and thirdly, because I am used to this. My whole practice is based on laser, laser proctology. That is the term which we use. So my whole practice is based on laser. So that is the reason I am more comfortable with laser. But choose a procedure which you are comfortable with. Choose an equipment where you are comfortable. So that is the final say from my side.
Right, sir. So thank you so much, sir. Thank you so much, Dr. Kamal Gupta, for giving us such deep insights and sharing your valuable thoughts on the topic of hemorrhoids and fissures. And with this, I would like to thank all our viewers also for their continuous participation and deliberation. Thank you so much. And with this, I would like to hand over the session to our sales head, Mr. Pranav Shah, for sharing his final concluding remarks. Thank you very much.
Thanks, Prodigy.
Thank you, Dr. Kamal Gupta, sir, for such a beautiful lecture and giving a good insight to a lot of doctors across the country. I believe if this lockdown would not have happened, probably a lot of people would not have got this advantage or privilege to hear you for a long period of time. So we really thank you for your valuable support, and on behalf of the entire audience, I would like to thank you for sparing your valuable time, sir.
Thank you, Mr. Pranav. Thank you very much.
Thank you very much, sir. Stay safe, sir, and stay safe to all of you.
Thank you very much.